Hello, my name is Nikila Singhu. I am an internal medicine resident at the University of Florida, and today I will be discussing our project titled Post-Ablation Atrioesophageal Fistula, a novel approach to diagnosis of a rare complication of cardiac catheter ablation in a critically ill patient. Atrioesophageal fistulas are connections formed between the atria of the heart and the esophagus that cause extravasation of oral and gastric contents, as well as air, into the bloodstream. It is a rare complication of cardiac catheter ablations. Often, patients present with ambiguous symptoms such as nausea, vomiting, and chest pain. The rarity of the condition and the nonspecificity of the presenting symptoms often leads to misdiagnosis or a delayed diagnosis. As a result, this condition has a high mortality rate as patients can rapidly deteriorate due to sepsis. In our project, we present a case that highlights the importance of prompt diagnosis of atrioesophageal fistulas and a novel approach to diagnosis in an intubated patient. A 75-year-old female with a past medical history of atrial fibrillation who underwent a radiofrequency ablation 4 weeks prior presents with a 2-day history of fever, generalized body aches, chills, shortness of breath, and mild chest pain. Vitals on arrival were notable for tachycardia with heart rate of 112 and a temperature of 100.2 degrees Fahrenheit. Her blood pressure was 128/98 and she had a respiratory rate of 18. On initial evaluation, she was alert and oriented. Initial labs showed a metabolic acidosis with a pH of 7.29, PCO2 of 41.1, and bicarbonate of 18.9, as well as elevated lactic acid of 6. Her white blood cell count was within normal limits at 6.5 times 10 to the third power. Urine analysis, respiratory viral panel, toxicology panel, and chest x-ray were all negative for acute abnormalities. An initial head CT was ordered, and as shown in Figure 2A, the patient had cerebral atrophy as well as a prominent anterior frontal CSF space, which was suspicious for bilateral subdural hygromas. However, this was considered non-contributory to her acute presentation. The patient then began to deteriorate rapidly with confusion and dyspnea. She then became unresponsive and hypotensive, requiring intubation and vasopressors. A CT pulmonary angiogram was then ordered for consideration of a pulmonary embolism. As seen in Figure 1A, no pulmonary embolism was detected, but a small focus of gas in the posterior wall of the left atrium was noted, raising suspicion for an atrioesophageal fistula. To confirm, a CT esophagram was needed. However, this was complicated by the orogastric tube in place. To overcome this, the orogastric tube was retracted to a position above the suspected atrioesophageal fistula, and then contrast was administered. As seen in Figure 1B, the CT esophagram demonstrated the extravasation of contrast from the esophagus into the atria, confirming the formation of a fistula. A repeat head CT was also done, shown in Figure 2B, which demonstrated diffuse multifocal infarcts, suggestive of multifocal emboli, which was previously unseen in the initial head imaging. Ultimately, due to refractory septic shock with diffuse embolic injury, the care team and family elected to transition to comfort-focused care for this patient. In conclusion, this case highlights the importance of early recognition and diagnosis of an atrioesophageal fistula in order to reduce the risk of mortality. The rarity of this complication and the nonspecific presentation of patients often leads to misdiagnosis or delayed diagnosis. If suspected, a CT esophagram is used to confirm an atrioesophageal fistula. In complicated cases where a patient is intubated, our case presents a novel diagnostic approach to confirmation of an atrioesophageal fistula. Here are our references. Thank you.